To people who are just joining and who've already joined, welcome. Good morning to our traumatic brain injury webinar. My name is Ricky Siddiqui. I'm in charge of strategic research here at Expert Institute. Thank you for taking time out of your day to join us on this presentation, which I hope will help guide your understanding of the medicine behind your legal cases, in particular, high-yield topics in TBI and diagnostic neurology. Before I pass it over to my esteemed colleagues, I want to take this opportunity to tell you about some of our services at Expert Institute. Dr. Shams, you can go forward maybe 2 slides. So our bread and butter service, first and foremost, is the expert search. Any category of medical or non-medical expert you need to testify in your legal case, we can find them. We connect you to the leading practitioners in any field and work really hard to make sure that even the most esoteric of your cases are connected with the right expert for the job. So secondly, as this slide indicates, one of our newer services is known as Radar, which is a profile on opposing experts, including but not limited to the full scope of their litigation activity, aggregating all the databases you would normally check, documentation surrounding these cases, like transcripts, publications, criminal background checks, license verifications, and more. Next slide, please. Thirdly, we go to the service known as Research Guides. Basically, it's a summarized compilation of any published information that exists on any topic of your choosing. What we do is find those publications, summarize them for you in an executive summary, and give you access to the primary literature and deliver a really polished executive summary to you, always written by a physician. And it's a great way to outsource the work of understanding the medicine over to us. Next slide, please. Finally, our service known as Medical Chronologies is this brilliant AI-driven way of taking the myriad of patient medical history records and summarizing them for you in a tangible, interactive format that makes it much easier to track the trajectory of a patient's care, including where the care has been mishandled by physicians and nurses, or what have you, and really an excellent alternative to digging through the medical records yourself. I want to just make one more comment is at the end of this webinar, all the attendees who are here are going to receive a link for a bit of a discount across all of our services. As just a thank you for joining us this morning. But without further ado, I want to pass the microphone to somebody who needs really no introduction, John Romano. He is a partner at the John Romano Law Group and is a civil trial advocate board certified by the Florida Bar. John, you can take it away if you can hear me.
Thank you, Ricky. Ricky, thank you very much. And I want to thank you not only personally, but also thank the Expert Institute. As you know, our law firm, Romano Law Group, we've been working with the Expert Institute now for many, many years, and the services you all provide have been just tremendous. It's been a great experience to work with Expert Institute. You all are responsive, reasonably priced when it comes to fees, and most importantly, you truly have professionals on board who know what they're doing day in and day out. And it's been just so refreshing to deal with such competent, skilled, and talented people. And that's what we see in the folks at Expert Institute. I am thrilled to be here today because we have Tanzid Shams, MD, who is going to be our primary speaker. And why this is so important is in this field of traumatic brain injury, it seems to be one of the hottest areas in terms of not only injuries to people in our country and around the world, but even more so when it comes to litigation. And yet there are so many lawyers who don't really understand the subtleties and the nuances of what is happening in these brain injury cases. That's why we need great physicians, great healthcare providers to to take us down this path on a journey of learning. And that's what we're going to have here today, a true guru in the area of traumatic brain injury. Let me tell you a little bit about our featured speaker. Dr. Tanzid Shams is Chief of Neurology at Ballad Health, a 23 hospital health network spanning Tennessee, North Carolina, and Virginia counties, with a total catchment area of over 1.3 million patients. He oversees 5,000 neurological consultations each year, covering head trauma, TBI, strokes, seizures, and many other acute neurological disorders and injuries. And he completed his educational training at Harvard University and Columbia University Medical Center. When I say he is a TBI guru, he is a physician who is always thinking what's best for the patient, the patient, the patient. That's the kind of doctor we want for our own care and treatment. That's the kind of physician you want helping you and guiding you through the issues in these cases and treating and caring for your patients. He is not only an expert in diagnosis of TBI, but also in those tests which help us confirm or verify the existence and extent of TBI. So it is a great honor and a privilege for us to have him with us today. And I'm going to turn the program over to Dr. Tanzid Shams, who will now take us on this journey through TBI. Dr. Shams, the floor is yours.
Thank you so much, John. Thank you for the kind introduction. I'm delighted to meet you all remotely. So, John, I think the core of this talk today is really not just maybe understanding TBI, but you hit the nuance on the head where there's a lot of subtleties when it comes to TBI. It's a very broad term. Our goals and objectives is by the end of this discussion and of this seminar, you'll have a solid understanding of all the objective tools, diagnostic studies, and clinical decision-making that goes through a physician's mind in a healthcare setting. And we'll go through these one step at a time, because understanding the objective criteria and the objective data, diagnostic studies will help you with your case theory and how to approach each case. Because as you know, from many, many medical legal cases, each case is very different. So I think our goal in this talk today is to really focus on explaining the clinical decision-making step by step. So let's kind of move forward. And this talk has multiple sections. I will signpost. I would say there's 4 or 5 mini modules within this talk. So we'll signpost. There's a Q&A section at the bottom. Our moderators are checking. They'll ping me if there's any pressing questions, and we'll have plenty of time at the end to take questions as well. All right. The one big overarching concept I want to start with is, that there's so many acronyms floating around, like, TBI, it stands for traumatic brain injury. But a basic visual biomechanical idea that I wanted everyone to take away at the very beginning is that it's something very anatomical. Whether it's a pediatric brain that's still developing or whether it's an adult brain, there's something unique about the structure of the brain. It's a kind of designed like a broccoli on a stem by evolutionary design, or a cauliflower on a stem. So anytime there's a trauma or an impact, the fluid-filled areas of the brain go through some forward-backward movements, right? So I think it's kind of important to understand, okay, what's at the core of this all? And there's something about our anatomy and physiology where the weight of the brain sitting above the stem is a little bit heavier than what's carrying it. And this is at the core of, what causes traumatic brain injury? What are we trying to evaluate? So I wanted to kind of start with this. In medical terminology, we talk about this in terms of what we call coup contra coup injury, meaning anytime there's a head impact, whether it's a fall at a nursing home, a car accident, sports concussion, there's kind of like linear forces back and forth that's working on the brain and kind of having sudden impact. It's important to understand that. And we see a variety of outcomes from this. Sometimes there are no bleeding. Sometimes there's intracranial pressure increase after these. And so we'll get into the details of this. Let's move forward a little bit. And, as we think about different forces that impact the brain and result in traumatic brain injury and long-term sequelae of traumatic brain injury, one thing to understand is that um, impact and trauma is not always linear. So it kind of depends on the setting. If you're in a military setting, let's say there's a blast injury, typically that'll be a linear injury. If it's a car injury, sometimes it depends the biomechanical forces that's acting on the point of impact. And if it's a side collision, sometimes there's a rotational component to it. Similarly, also in sports setting, it's not head trauma is not always a linear component, but there's also a rotational component to it. So I wanted to, once again, if you go to that analogy of broccoli on a stem, it's not just linear forces, but rotational forces that are also working on an organ that's only 8 to 9 pounds, but many, many heavy G forces are working on this organ, which results in trauma or impact. So we'll start with kind of like a case scenario, and it's a theme that walks through this talk. Many folks who are on this talk today, I imagine each year I end up doing probably 50 to 100 case clinics with different legal teams and attorneys. And one of the common scenarios that often comes up is patients in a motor vehicle accident. But you can kind of replace this for whether it's a fall, whether it's any other form of heavy trauma. In our clinical scenario here, we're dealing with a patient who's been in a car crash. So one of the first things when patients arrive at the, in an emergency room setting, there's some key things that the emergency room is always sizing up. This trumps everything else. It trumps CT scans, it trumps blood oxygenation. The first thing we look at is the patient breathing properly? Because it's primary to stabilization, right? Number two, is there good oxygenation? Is there airway and breathing working okay? Is there circulation okay? And what are the other disabilities and what type of environmental factors affected them? Usually that we kind of take a close look at the head, eye movements and so on. So there's cranial assessment, and also we worry about the spinal stability. And once again, it goes back to if you have a heavier organ on top and a leaner, spinal column that's stabilizing it, the spine can be destabilized also. So, in summary, it's called ABCDE, but this advanced trauma evaluation is at the very core. As soon as the patient gets brought into an emergency room or a critical setting, that's one of the first things we kind of evaluate and try to determine, like, okay, before anything else, do you need to intubate this patient and so on? But that's a little bit, more for the emergency room. And once the patient is kind of a little bit settled in, if we say that the triggering event was the trauma, it kind of gets triaged in a couple of different ways. So a closed brain injury is when there hasn't been any fractures of the skull. Maybe there's not even any evidence of bleeding. The patient's stable. They're breathing okay. Their airway, oxygenation, everything's stable. So that's kind of one pathway. You observe the patients, and we'll get into what diagnostic tools and things we get into. Also, sometimes you can have penetrating brain injury where either there has been a skull fracture or a foreign object or a metallic object has caused some sort of compromise in the external and internal structures of the brain. So that's a whole different triage. Typically, those patients are intubated, taken to critical care units or operating room and so on, right? And there are a few other forms of non-traumatic brain injury that can occur from strokes and seizures. And we'll kind of look at that closely. But next thing we're going to emphasize is that when you review medical records, when you're reviewing a case, you'll see a ton of terminology and different diagnostic tools that are used. So I want to start with this scale. On any sort of a motor vehicle accident, in the emergency room intake sheet, look for this. Look to see what the patient's Glasgow Coma Scale was. Essentially, it's a scale designed way back in the 1850s in Scotland, and it kind of correlates. The higher the score, the more stable the patient is, and the lower the score, the more severe the brain injury. And when we've done 90-day outcome, 180-day outcomes, we find that this initial Glasgow Coma Scale actually has a correlation with how the patient does in the long term. So if somebody came in with a Glasgow Coma Scale of 15 and we'll explain the scale in a minute, we think we kind of categorize then, okay, this patient may have a minor brain injury. On the other hand, if their Glasgow Coma Scale is, below 8, they're typically in a comatose setting, and that correlates with severe brain injury. So when you're taking an intake, looking at emergency room notes, I look for that to see, all right, what was that patient's initial presentation? Because it cues me off to, kind of having a sense of how will this patient do down the road, okay? All right, so let's kind of look at the scale more closely. There's 3 parts. There's eye-opening, verbal response, and motor response. And we give the patient a point score based on each one of these scales. So for eye-opening, it's a scale of 1 through 4. For verbal response, it's a scale of 1 through 5. And for motor response, it's a scale of 1 through 6. And, they're different kind of some of it's observational, some of it's Q&A based. We ask the patient to open their eyes, and if they're opening spontaneously. So you pick one of these 3 numbers in these 3 categories, and you tally them. So the maximum you can get is 15, and below 8, you're in the coma range, and 0 is kind of practically incompatible with life. But this is what the scale looks like. And every single emergency room, nursing team, the EMS services, emergency room doctors, they kind of go to this scale initially to kind of categorize the patient. All right, how do I need to triage this patient? Okay. All right, so let's go to the next step. So let's do some correlation here. If a patient comes in a car accident or head trauma, so somebody's initial, when their Glasgow Coma Scale is 13 through 15, and maybe there have been brief mental status changes, some fatigue or headache, and there hasn't been any major loss of consciousness. They may have been confused for a brief period. That is classically categorized as mild TBI, mild traumatic brain injury. And then, Glasgow Coma Scale of 9 through 12, maybe they've had some alteration of mental status and they're still confused beyond the first 30 minutes. There's perhaps been some physical damage and so on. So that's moderate TBI. And then Glasgow's Coma Scale of 3 to 8, that really falls in severe traumatic brain injury. Most of the time, these patients do need to get intubated. They have prolonged loss of consciousness. They may end up in an ICU setting and may remain intubated for multiple days. And, these patients are certainly unconscious on presentation and may even have longer stay due to their comatose state. All right. So let's go to the next slide here. Right. So some of the leading causes of TBI, we kind of referred to this. It could be falls. It could be some sort of aggressive altercation, motor vehicle accident, assaults. Any number of these things can lead to TBI. And according to CDC analysis, approximately 2.5 million cases of TBI land in different emergency room and healthcare settings. And to be frank, if we include sports and sports-related concussion, this number definitely exceeds more than 5 million because independent of trauma, if there's a whole other bucket of just life happening, people falling at home, people falling in nursing home, younger kids getting hurt in a football practice or lacrosse practice. So we add that all up, this can exceed more than 5 million. So, all right, let's just say the patient has been triaged, their Glasgow Coma Scale has been evaluated, you've identified the mechanism of, what the mechanism of injury is. So now we'll move to kind of the next module in this talk and try to talk about, before I go forward, after the patient has been triaged, a clinical provider has a set of diagnostic tools that they can use. Now, if you open the chart, and I'm pausing here on purpose, I'm trying to cue your brain to think about different things you might see in a medical chart or when you're talking to your clients. They'll say, hey, I might have had a CT scan, I might have had an MRI. So going forward for the next module, I want you to keep in mind is that the next set of diagnostic things and imaging that we're going to talk about is really more in an acute setting, as in the immediate setting after trauma. And then we'll talk about things that are more long-term in nature, all right? So immediately when a patient comes in with trauma, all patients usually get not just a chest x-ray, but typically there's an evaluation of, they call it trauma screen. So shoulders, legs, hips, chest, there's a set of x-rays done just to check if there has been a fracture, especially if the patient's Glasgow Coma Scale is somewhat low, okay? And then a CT scan is done pretty often, because I want you to think about CT scan as somewhat of an acute brain X-ray. It's an X-ray based technology. It takes a maximum of 30 seconds to get done once you get a patient to a CT scan machine. So it's really an X-ray based technology that gives us an analysis of the bones and the blood vessels and the soft tissue of the brain. Now, if a patient gets admitted to the hospital in the first 24 hours and they're having cognitive issues or they're unconscious, that's when an MRI is done. I think this question comes up a lot in traumatic brain injury cases, that, hey, should an MRI have been done to identify a subtle bleed? I think I wanted to make this point that in the acute setting, let's say in the first hour, 2-3 hours, the only feasible studies are really X-ray based studies, because an MRI, even though it's a much more detailed brain imaging, it's a magnetic study. It takes about 45 minutes, an hour to stage the whole study, and the patient has to be somewhat stable to hold still and be in that setting. So it's not always a practicality to take a patient who's come in from a trauma scene, they're bleeding, maybe they have a fracture. So many other things may need to be stabilized. It's not always just, knee-jerk X-ray CT scan. So the MRI is usually held off until the first 24 hours or so. Once there has been much better triage of, does the patient have a fracture? Do they need any emergent surgeries? And then an MRI is something that's pursued. But this is all still within the first 24, 48 hours. Okay, so let's look at some, brain scans. So this is a CT scan. It's X-ray of the brain. The slides, this is showing you kind of up and down different sections of the brain. For those of you looking along, these are the eyeballs. These are our sinuses. This is a nice, clean, clear-cut X-ray. All right. Now, we have positive findings depending on the mechanism of injury. So this would be a classic intracranial bleeding. You can see almost a layer of the brain that's getting separated. So there are arteries and bridging veins right here on the surface. So one take-home point, if you're reading a CT scan, you might see that they'll use the term hyperdense, and that's the terminology that's used for things that are bright on a CT scan. You might see the term, there were hyperdense lesions or, hyperdense areas of the brain. It's in general looking and sharing to the reader that, okay, this patient who's come in, who's had an acute CT scan after a trauma, there's an intracranial bleeding. There are different types of bleeding, but the ones that are large are typically visible in a CT scan. There are many different types of bleeding. Some are slow, some are subtle, some take a long time to accumulate. It might take 7 days, 10 days to slowly expand. And those slowly expanding slowly expanding intracranial bleeding is not going to be picked up on the initial CT scan. So this is another subtlety to keep in mind, that even though a CAT scan is done, if it's very, very small and slowly expanding, that bleeding will not be picked up on a CT scan. The blood has to be large enough and bright enough to be seen and picked up by the radiologist. So there's some subtleties there. Okay. So if a patient like that comes in, who has blood in their brain, typically their pressure in their brain is high. There may have some evidence of penetrating head trauma. There's obviously evidence of intracranial bleeding. In those cases, we consult the neurosurgery team. They get involved. On the other hand, if you have someone with a high Glasgow Coma Scale and they may have some mild cognitive deficits, a neurologist is typically consulted. So one way to think about these two specialties is that, a neurosurgeon cuts into somebody's brain and a neurologist kind of deals with more the medical side of a patient's clinical issues, namely their blood pressure, their intracranial pressure, managing these patients in a critical care setting, and so on. All right, so I'm going to pause there. That all of that was part of the initial X-ray screening, CT screening, perhaps if necessary, an MRI of the brain. This is all part of inpatient trauma stay in an acute setting, right? So we haven't let our patient go yet. Like they're still in the first 24 hours, they haven't been let go of the hospital. And these are some of the clinical scenarios and ideations that are playing out in a real clinical setting. Let me pause. I'm going to see there's some Q&As there in the box. I'm going to take a look. All right. So William McMurray has asked, does there have to be a fixed object in whiplash case to cause mild traumatic brain injury? The answer is no. You can have an impact with a moving object, you don't even have to hit anything hard. Just in a whiplash setting, that we talked about that coup contra coup injury. If the impact force is high enough, there can be a sudden jerking motion depending on a velocity of a moving object. There can be a sudden stop and go type of action that impacts the brain and cause pressure and torque on the brainstem. You really don't have to have a fixed object or direct impact with something hard. A velocity of a moving object or a person inside a motor vehicle accident can be hard. I think that was the context for this question. And let's see, Courtney Wilson has asked, can you discuss determination of what loss of consciousness is, not just an unconsciousness, but confusion? Yeah, I think, Courtney, we certainly, I'll give you a brief answer here for the sake of time, and we can talk a little bit more about it towards the end, perhaps. So typically, the three classic questions that an EMS team is asking is going to be things like, do you know today's date? When is your birthday? Where are you right now? They're typically awareness, orientation questions of your everyday functioning and how are you aware of your whereabouts? So that's kind of the immediate triage. But beyond that, the loss of consciousness question, if you go back, and I think the slide deck will be made available, if you go back to the Glasgow Coma Scale, that's a good place to put the whole loss of consciousness, because you're trying to kind of grade the patient in terms of how confused are they, how conscious are they. So once again, if a patient is not able to talk, they're completely comatose, their Glasgow Coma Scale is going to be below 8. And if they're alert and oriented, maybe they're a little bit foggy, a little bit headachy, we try to scale them on a Glasgow Coma Scale, it's going to be closer to 13, 14, and 15. And we can get into more of this, okay? So let me pause and kind of say that, okay, now we're moving to the next module in this talk. And often, you get a scenario where a patient says, maybe 2 weeks later, they've come into a clinic and they say to a clinician, and this would be typically an outpatient neurologist or a psychologist or their internal medicine doctor, or even a chiropractor, they may say, hey, since the accident, I've been kind of feeling foggy, I'm feeling down, I just don't feel right about things. So this is a very common set of signs and symptoms. And this is the part of TBI. Now we're getting to like the nuance part of it that makes it such a elusive process, because it's hard to there's no imaging study for depression or anxiety or chronic pain or headache. It's not that there is a singular imaging study, but we find that patients who have had even a mild traumatic brain injury often will have exacerbation of symptoms like this. So there's two scenarios. Imagine a patient who had none of these pre-existing conditions. If you have mild traumatic brain injury, in the first 2 weeks, we see plenty of patients who are susceptible to depression, anxiety, chronic pain, headache, migraine, vision problems, cognitive difficulties, and so on. And if you have a scenario where a patient has pre-existing conditions, any one of these conditions, we certainly see exacerbation. And this is just a clinical presentation where a patient comes in and they kind of started reporting these symptoms. I wanted to go back to that idea is that, okay, why, if we actually take a step back here, this is pretty broad: depression, anxiety, headache, vision. It's multiple different functional areas of the brain. And why is this? The underlying theory is that it goes back to that biomechanical forces during even mild traumatic brain injury. Sometimes you can have a shear and stretch injury of the nerve sheets, which causes inflammation. So the rotational forces, the linear forces that work on the brain, they can stretch and pull the nerves, and they can cause secondary inflammation. So I think that's an important thing to keep in mind. And if the trauma force is, hard enough, and that stretching is hard enough, you can have long-term inflammation sticking around the brain. Now, the hard thing is that to this day, this is the holy grail in traumatic brain injury research. There's not a blood biomarker. There's not a singular bloodborne test, something you can give someone just like a glucose test or something where you can say, all right, I have identified a singular blood biomarker for how severe one's brain injury is. Unfortunately, it is the nuanced part of this is that the patient's own reporting of their signs and symptoms is something you have to take at face value, and then take a look at what was the mechanism of injury, what setting were they hurt. And some other exciting new things that have come up. Can everyone see my cursor here? My cursor, is that visible? I just want to see if the audience can see this.
Yes. No,
Yeah,
it's
we can see.
visible. Yes.
Good. Wonderful.
Easy to see.
Very recently, if you look at this layer between the bone and the brain tissue, in 2018 until now, there's been a couple of very interesting, exciting papers that have come out that there is a layer of lymphatic cells just at the surface of the brain that can get inflamed. Not just the nerve endings and the nerve sheets, but actual lymphatic cells at the surface of the brain that's kind of in a layer between the bone and the brain tissue that can cause chronic inflammation. So this is, for the longest time, people have been trying to figure out, why do people get depressed? Why do people have cognitive issues and memory issues? And there's this search for like, oh, let's find a test. But so far, the whole explanation and understanding of this is a little bit more based on the general physiology, and no singular test has been identified. So let's keep moving forward. So all of those symptoms we talked about, right? Headache, dizziness, irritability, balance, these things, if they persist, for more than 2 weeks, now the patient is getting into a kind of an area where we start to categorize this patient as post-concussive. They have something called post-concussion syndrome. And if the symptoms persist for greater than 3 months, then it's really identified as persistent post-concussion syndrome. So one of the things I want to kind of correlate is that this comes up a lot. Patients with severe traumatic brain injury, certainly you would expect them to have prolonged concussion, but we see quite a bit that a patient with mild traumatic brain injury can still have persistent post-concussive syndrome. And why is this, right? It kind of goes back to this idea that no two individuals alike, no two brain is alike. There's a certain subset of population that is more susceptible to axonal injury, to nerve injury, to inflammation. And the underlying theory is that the person who's more susceptible to that is the person who's going to have prolonged post-concussion syndrome. Why is it that, athlete number one can have 10 sports concussion and they're fine, they don't have any long-term issues. And you have a different athlete who have 1 or 2 concussions and, they have school issues or performance, memory issues, and so on. So I think there is an elusive, nuanced nature to this. And so far, what that unique component is about an individual that makes them really susceptible to long concussion symptoms and prolonged TBI symptoms, that really hasn't been identified. It remains a holy grail in this literature. I want to be humble about it. All right. So now imagine, a patient is sitting in front of a neurologist, they're in a clinic setting and they're kind of reporting their signs and symptoms. So we'll kind of look into the exam section, but once again, let me pause and let's check the Q&A section for a second. Let's see, let me invite my moderators, Ricky and Michael Morgenstern here. If there's anything pressing, I certainly would want to triage these a little bit, but let's take
I'd say nothing quite pressing at the moment. These are all good questions, but I think we can reserve them for the very end of the discussion.
Right. Yeah, because there's some pediatric questions here and blood markers and so on. So yeah, we can go through them at the end. That's great.
Doctor, let me jump in just a moment, just to follow up to a couple of things that you've said. I want to make sure that on the loss of consciousness issue, what we see a lot is that people come into an emergency room and they're asked a question by somebody, did you lose consciousness? And they say, I don't think so. And then the person in the emergency room puts a little check mark, no LOC. And often everybody needs to understand, all the lawyers watching this, there is no investigation done, medical investigation by folks in the emergency room or paramedics out at the scene, EMTs. They just go, she said she didn't think she was unconscious. Here's the problem with that. They don't know. Often a boxer will go down and be out cold for 15 seconds, 30 seconds, a minute or so. When the boxer comes to, denies having been unconscious. Football players get knocked out. 30 seconds later, the guy's up, he's on his feet, and they say, hey, you were out cold. No, I wasn't out cold. I wasn't knocked out. That happens often where they don't know. So what you've got to do is make sure that you investigated to see what was going on. Were they really unconscious? Were they dazed, confused? One that I've seen a number of times where a police officer arrives and says, all I can tell you is she looked like she had her bell rung. Well, those are magic words to people in sports. That means you either got knocked out or you got knocked crazy. You got to be looking for things like that. One second thought, and then I'll turn it back over to the doctor, is this. When there are gaps in treatment before the case gets to you, that's not on you as the trial lawyer. But once you agree to take on the representation of the client, and then after that there are gaps in treatment, that's on you as the trial lawyer. Part of our responsibility is to make sure that the client is getting the necessary continued, updated care and treatment. So you don't want to be handling a case and then be in trial and they say, well, there were these gaps, 6-8 months, no treatment at all, at a time when the case was in your office. If you let that happen, that's on you. Doctor, I'm going to turn it back to you.
Absolutely. John, your first point is so astute. And, even I do a lot of frontline sports concussion assessment, and whether it's an NFL team, NHL team, there is a moment where individuals aren't just check boxes. And even if they say, this is the paradoxical thing about head trauma, that the patient himself or herself has no recollection that they had a confused fugue-like state on the site. By the time they've arrived, they're somewhat alert. But the reality is that, a car moving at, 50, 60 miles per hour, and if that came to a sudden stop, the sloshing and the impact on the brain certainly causes a level of impact that I think we need to take that into consideration when you're evaluating this case. So excellent point. We'll move forward. So next, now you have to imagine that patient, let's say, who got triaged at the hospital. They were okay. They didn't have any intracranial bleeding. So now we're kind of moving to an outpatient setting where they may have come into a neurologist clinical office. And these are some of the things that are getting checked in an office setting. So when you're doing chart review, really look for this. A good neurological evaluation should contain the term cranial nerve. Really refers to these 12 nerves that are in and around our eyes, face, mouth, and swallowing function, and so on. So our ability to move our eyes properly, our ability to make proper facial expressions or enunciate sounds or not have word finding difficulties. All of these things kind of fall under the cranial nerve function. And then motor function really refers to more our generalized ability to move our bodies. Sensory function is pretty self-explanatory. The term cerebellar function refers to an organ at the very back of our brain, a smaller organ that sits at the very base and back of the brain that is more responsible in balance and coordinated eye movement. So cerebellar function is important for patients who may have had high impact towards the base of the brain or neck trauma and so on. So a lot of those patients often have balance issues and coordination issues. Gait is also important, whether it's direct trauma due to some fracture or people have functional deficits. Because of that trauma, sometimes people's ability to move their arms, legs, and have a fluid gait can be affected. Typically, in traumatic brain injury patients who are in a clinic, the reflexes remain intact. I don't find that reflexes are that much of an issue. And finally, language is, and if we bring memory function into this memory, executive function, recall, as this is being evaluated by neurologists very early on, this is something that is good to look at. If you're sending a patient for independent medical evaluation, it's very important to include these functionalities like language, like memory, and so on. And we'll get into a little bit more of this. So, let's say this doctor pulls up the CT scan and says, hey, we looked at your CT scan from the emergency room, looked like a normal CT scan, but you're telling me you have headache, you have anxiety, you have depression, you have tingling of your hands and feet, and waking up in the middle of the night in a kind of anxious sweat, not able to sleep, or you're having difficulty maintaining your high functional IT job, or having a difficult time functioning as a police officer because of some recent trauma. So this is where we kind of start to get into, all right, like what can we do next, and what are the things that we can do next? So this is terminology introduction. We don't want to get too technical, but an MRI stands for magnetic resonance imaging. Even in an outpatient setting, some providers can choose to do a new MRI with a broader set of sequences. So the MRI has multiple different modalities. It's not just one image. The reason why it takes 45 minutes to do it is there's multiple different sequences within the MRI. In a hospital setting, sometimes not all of that is being done in a comprehensive way. There are 15-minute shorter protocols in hospital MRI because you have to keep patients moving. And also things like slow bleeding, chronic inflammation, injury to the nerve sheets, we call it axonal brain injury. Those things are subtle and they may take a little bit longer to manifest. So when a patient comes into a clinic 2 to 4 weeks later, and a student neurologist would say, all right, let's get a detailed MRI that makes sure that we have all of the sequences, okay? So a T1 segment, it typically shows if there's any blood-brain barrier that's been broken down and if there's inflammation. So if a patient has things like slow leaking blood, even prior history of stroke, those things will show up. I don't want to make this too technical. I just want to introduce you guys to the terminology. We'll keep moving forward. A T2 sequence typically detects intracranial hemorrhages, arteriovenous malformations. If there's any cancer, tumor, malformations, that might be more visible in a T2 sequence. A flare sequence is something where the overall fluid level in the brain is suppressed, so you can see the solid structures a little bit better. So, when you're looking at often, most medical records or patient records, your client records are not going to come with images, but you'll see these terms. The MRI flare sequence may show some sort of damages or hyperintense lesions and so on. So that's another sequence that is common. Let's see, DWI stands for diffusion weighted imaging. It's a great sequence to detect stroke and tumors and brain atrophy patients who have pre-existing history of dementia. Each day in a hospital setting, I get to look at 20 of these. If I see 20 patients, each patient often comes with a CT scan or an MRI. And I cannot tell you how many cases I've looked at where a person with pre-existing brain atrophy or dementia symptoms often will also have TBI symptoms, and these things can be hard to tease apart. So having this type of diagnostic imaging early on can really help you understand your case. Like, well, did the person had atrophy in their brain before they were even hurt? What was their baseline? Did they have Alzheimer's disease? So DWI sequence is great for that. And the final two sequence for the DTI, this is very exciting. It's three-dimensional. It's color corticography, multiple modalities. We have a whole section on this talk on DTI, so I'm going to elaborate on that later. This is not available to an everyday radiologist. This is not available to an everyday patient. You have to go to a special center to get this done. So we'll kind of talk about DTI because it's kind of a crown jewel in terms of what we're finding from DTI. And finally, based on the examination and findings, a patient may require spinal imaging because they may be having arm and leg issues or gait issues, which all of that may not be based on the brain because of the impact force. The patient may have had spine damage or spinal inflammation, right? So the tricky thing is that when an MRI of the brain is done, if we take all the mild traumatic brain injury, 99% of the time, the patient's MRI will be normal, right? Majority of the time when the MRI is abnormal is when there's severe TBI or if the patient has a pre-existing condition. So the MRI is really helpful for us clinically, not necessarily medical legally. The MRI is most helpful for us to understand what the patient's baseline brain looks like. So if they have Alzheimer's, if they have multiple sclerosis, if they have prior history of stroke. Once again, I think the reason I'm talking about the absence of things in concrete, solid imaging is because this is the kind of the diffuse, elusive nature of TBI, that so much of it is symptom-based. A patient who have had mild traumatic brain injury actually may not have any positive findings on the MRI. It's a little bit paradoxical, but bear with me, this is just how things are. So now, like what's a clinician to do and what is a patient to do and what is a lawyer to do? You're like, hey, the CT scan didn't show anything, the MRI didn't show anything. What are we going to do? There's all these symptoms like headache and depression. Your client's telling you, hey, I can't function in my job. So there's 4 or 5 other things that are typically done and investigated. And what John was talking about is that if your client has not had these modalities, it's okay for them to go and get this evaluation. Once they're in a relationship with you, you can, kind of start to see if some of these diagnostic studies have been done. So think of this as kind of the next module in our talk. Beyond your basic, CT scan and MRI, we're going to delve into a set of diagnostic studies that adds additional valuable information to understand and analyze the extent of damages from traumatic brain injury. Okay. So an EEG, so let me slow down here. It's usually 16 leads. They're sticker-like stickies, essentially, that are placed on the surface of the brain. And some of the advanced one can be 32 or 62 leads. And it's recording electric activity of the brain. So normal individuals should have, all of us hopefully are awake talking, have had our morning tea or coffee. So normal individuals have a symmetric right and a left brain activity. And patients with traumatic brain injury can have slowing in their brain activity. So I think while this is not singularly, that it's not like, oh, hey, the EEG proves everything. But if a patient has, focal brain activity slowing in an area of the brain where they've had prior injury, this is something to look at. Typically something subtle like that may not show up structurally on a CT scan and an MRI. On the other hand, the electric activity of the brain, which is a very different type of modality, may be abnormal. So this is a diagnostic study you should know about. Another study is called nystagmography, where a patient with cerebellar injury, brainstem injury, remember that, cauliflower on a stem stalk, so the base of the brain often suffers a lot of impact in addition to the front and the back because of impact forces. So the cerebellum and the base of the brain, which is kind of the bottom part and the top of the neck, those areas are very responsible for eye movement. So this, and a fancy term for abnormal eye movement is called nystagmus. Often we see these patients have erratic eye movement. So there are ophthalmologists and vision testing labs where you can get abnormal eye movements tested, and their eye movements are tracked through this type of analysis. Something good to know about, if a patient talks about vision problems, but all the medical records saying, hey, their vision is normal, this is a diagnostic study that can be helpful. Also, a very simple test: patients with head trauma and concussion can have heart rate variability. So a good recording of their heart rate, at least at the time of giving this talk, even your iWatch or many wearable devices can track your heart rate, and most cardiologist offices have this. Typically a few weeks after a concussion, especially if this was a severe concussion or mild traumatic brain injury, it's really variable depending on which patient has it, but at least the presence of heart rate variability can cue you in to say, all right, there is something erratic about this patient's overall disposition. Their heart rate's shooting up and down. There's something physiological about head trauma that eventually affects people's heart rate and the variability. So I think if your client hasn't had that, this is something to consider. Okay. Olfactory testing is another one. Once again, if you look to the right of the screen where my cursor is, right above the nose, there's tiny cilia, what we call it cilia, and they are small attachments and nerve endings that can pick up scent. So a lot of patients, incidentally, patients with COVID also have loss of sense and taste, but patients with head trauma, because of that impact force, often will have loss of scent. So as you can see, we're getting really subtle. On one hand, earlier on in the talk, we had CT scan and MRI that shows you structural things, but then, findings from traumatic brain injury can be something really subtle, as simple as loss of sense. So when you have something so elusive like diffuse symptoms like depression and anxiety and headache, finding something concrete like loss of scent, that can be something concrete that might be supportive of your case. Okay. And then finally, there's a whole field called neuropsychological testing. So think of this as our next module in this talk. It's much more detailed test of our neurological functioning. This goes beyond a half an hour, 45 minutes at the doctor's office. A neuropsychologist is typically a PhD who is trained in a much more detailed analysis of person's memory, language, reasoning, motor function, and mood. And let's kind of go forward and kind of take a look at this. So I think whenever we're talking about traumatic brain injury and damages, there's a question of malingering that often comes in where if one of the only ways if a person, your client or a patient can describe damages is by their own self-reported depression, anxiety, memory function. How do we know that this patient is not malingering or saying something for secondary gain? So that's what's kind of neat about neuropsychological testing, that the test itself has built-in validation questions that it can tell you if a person is malingering or embellishing their responses. So I think that's something really essential and a very high value in neuropsychological testing. For you to have time value to spend a lot of time on a case in a traumatic brain injury case, if you're going forward with the case, it's very essential. I highly recommend having a neuropsychological testing. And there's a lot of different components to it. Today, I'm just going to introduce some of the section. So Wechsler's test for adult reading, that's usually a complex word reading task. Paced auditory serial testing, that's a complex mental testing of you hear numbers and then you're kind of adding numbers in sequences, some mathematical component to this. So that's serial addition test. There's a verbal learning test where a list of words are given and your recall is tested. There's attention and working memory where people are given a certain number of digits in a sequence. So for example, you might be asked to recall 5 digits in a row or 6 digits in a row, and the test just goes higher and higher. In reality, a good neuropsychological testing can take anywhere from half a day to full day. There's built-in breaks between these modules. It's really a prolonged testing, and perhaps one could spend an entire talk on just what neuropsychological testing is. There's a cognitive self-reported questionnaire, anxiety inventory, depression inventory. So as you can see, it's really comprehensive as far as the psychological, the language, the memory components of this. So I think that's always good to acquire and obtain. And one other thing I'll say is that when you get a neuropsychological test, at the end in the summary, a good neuropsychologist will report a couple of things. Number one, they will give you a percentile function, meaning in all of these modalities, what is the person's functionality? Are they functioning in the 95th percentile or are they functioning in the 35th percentile? So that also kind of gives you something concrete, because CT scans and MRIs don't always come with a number. But if you have a clear history of trauma and a clear history of some psychological signs and symptoms, when you do a neuropsychological testing and the report comes with a percentile deficit in different areas, and the neuropsychologist should and ought to comment that, hey, they felt like the person was giving full effort, they were, not malingering and so on. At that time, that becomes somewhat of a concrete, valid inventory of a patient's signs and symptoms that may be resulting in long-term damages from traumatic brain injury, right? So, and then the next module will kind of talk a little bit about something called diffusion tensor imaging. This is something very exciting in terms of, we call it tractography. So I think I put this slide up one more time, because CT scans and MRIs, these are in black and white. But if even from like a layperson's point of view, let's take our medical hats and legal hats. One thing I think, as to me, from the time I was perhaps in my college years, one of the things that was very fascinating to me about the brain is that the brain is an interconnected organ. It's not isolated. It's not that our memory function is functioning independent of the language function or our ability to recall something, that works together with our ability to do a math problems and so on. So a diffusion tensor imaging is really a little bit more. I'm going to jump forward to see what the image looks like here. Let me show you guys this. It's a very exciting, this is more like a normal person. So there's a whole set of academic medical centers and some private centers around the country that can do these diffusion tensor imaging. I really want to kind of say this caveat that unfortunately, this is not something available to everybody everywhere. Maybe the large urban centers in Texas and Los Angeles, New York, Miami, you have access to this, where a diffusion tensor imaging the summary of it and the report of it can really comment and go well together with your neuropsychological testing. So if a neuropsychological testing says, hey, there is deficits in this person's memory, and you identify the areas of the brain and the tracts of the brain that are responsible for memory and recall, I think this can be a nice addendum, a nice supplement. But the brain is complex. It's not like, not every case is going to come tied up in a bow. You might get conflicting evidence. This is the nature of science and the nature of diagnostic modalities. They don't all come tied in a bow, but if available, diffusion tensor imaging can be a really nice concrete tool for you to say, if the CT scan was normal, if the initial diagnostic studies in the emergency room was normal, like how do we take it all together and quantify and put forward an elegant way to say a patient has had some damages. So diffusion tensor imaging is a nice way to show the different tracts and damages in a person. It's a little different than a general MRI. Like I said, it kind of talks about the connectivity, the interconnection of different parts of the brain. It comments on some of the functionalities. And typically, if all is done well, it goes well with the neuropsychological testing. So I think I'll pause there. I think we've kind of talked quite a bit today. We're at the 11 o'clock mark right now. We have a good amount of time for Q&A. I think it's more fun when John and I talk a little bit more and jump in and give you perspectives. And I think we'll kind of stop and pause our talk there. Basically, I think we won't belabor on this slide too much. I was just sharing it with you guys visually that how diffusion tensor imaging really has a nice color coding. It's concrete, visually it makes for a nice presentation. It can focus on different functionalities on these patients. And then, like just to close out this talk, in spite of all of this, when a patient goes through neuropsychological testing, DTI, I'm sure you guys have had clients like this, and I have patients like this. These patients have long-term outcomes, whether it's mild, moderate, or severe traumatic brain injury. The brain is a very susceptible organ, and high impact forces can really affect it. Part of my inspiration for being a clinician is that I get to be front lines for these cases. I'm in the emergency room, I'm in a critical care setting, I'm looking and seeing these patients in the front line. And, this is what inspires me. My job is to really stabilize these patients, do the best that I can for our patients, and, in spite of all of the diagnostic modalities, one of the hardest things about traumatic brain injury is that a small impact force on the brain can have really long-term effects, down the road. And you can even have, confounding things like people with pre-existing depression, anxiety, dementia, ADHD, all of those symptoms get worse after a traumatic brain injury. So let me pause there, and John and I will take questions, and I'll also open up the Q&A box if our moderator wants to jump in. We can kind of look at these one at a time. What do you say, Ricky? Or
let me.
Yeah.
I'll jump in there with a comment.
Yeah.
One item that I would like all of our attendees to be thinking about is this. These TBI cases bring to us brain injuries which are so serious. In fact, it has been said that a brain injury is an amputation of the soul. I've actually used that phraseology in a summation before, and it's so true. But in one case that I tried several years ago, my co-counsel suggested, isn't this really like a wrongful death case? And I was trying the case with Doug Beam and with Liz Weibel. And Liz mentioned that one of the children had told us, the children of an injured dad. And the young son had said, when dad was injured, and then he went through all this recovery, and then he came back to us, I must tell you, dad is dead. A new person arrived on our doorstep when he returned. And Liz said, maybe we should try this like a wrongful death case and perhaps get a grief and bereavement expert involved. And I was questioning that, but as Liz began to explain it more and more to myself and to Doug Bean, I understood where she was going. So we made a decision to have the wife and the 3 children examined by a psychologist who does grief and bereavement work as a part of his practice. The defense took the deposition of the grief and bereavement expert, and then they filed an assortment of motions to keep his testimony out, but the judge allowed it. Not that we were trying to say it was a death case, but we were saying that the spouse and the children, and in that case, we had a loss of consortium claim for the wife as well as for each child, which was allowed under Florida law in that situation. And under those circumstances, the grief and bereavement expert testified about the loss to them and the grieving they go through over losing dad and having dad replaced by somebody else who in essence shows up. So it's something for you to be thinking about, the serious consequences of what happens in a brain injury case. I heard someone say only recently, it was actually a healthcare provider. Don't confuse a concussion with a brain injury. And I asked this person, well, what is it that gets hurt when there's a concussion? And he said, well, the brain. I go, well, then it's the brain that is being injured. So a concussion is a brain injury. And a lot of times the nomenclature gets confused and it gets into medical records and it can harm your case. Make sure that you have a highly skilled and talented physician or medical person you are working with on these cases so that he or she can guide you correctly on this journey. With that, I'll jump in. Do we have any questions there, Doctor?
We do. We have an excellent question. Actually, there's about 15 questions that are there. Hopefully, we'll address them all. Let me take question number 2 because it segues really nicely. Jeff Martin asks, is a concussion a TBI, or does a concussion diagnosis equal a TBI? This is a excellent question, Jeff. So before 1980s, the word concussion didn't come into the medical vernacular as much. A mild traumatic brain injury was treated as it was kind of interchangeable with the term concussion. Now, does a concussion diagnosis necessarily mean that the person has TBI? The real answer to this question is that 95% of concussions that occur in everyday life in sports setting, these patients will never have long-term sequelae. So I think a better way to think about this is that, and most concussions are mild in nature. Like you might have been skiing and you fell, okay, you're a little bit confused, everything is fine. Or, a 12-year-old kid who's playing tag football gets hurt. So the better way to think about it is a term we used, post-concussive signs and symptoms or post-concussion syndrome. If the signs and symptoms are persistent for more than 2 weeks, you have a diagnosis. Whether we call it mild traumatic brain injury, whether we call it post-concussion syndrome, it's less relevant, like as long as you have an expert and someone who can articulate that, look, there was a clear mechanism and there's some clear set of signs and symptoms that are persistent. So I would say just a single incident of concussion alone doesn't make a diagnosis, or a single incident of, some sort of a knock to the head alone doesn't give you the ultimate diagnosis. For us as clinicians, what we're really looking for is that, does the person have credible signs and symptoms that persist beyond that initial period? So Jeff, I think a better way to think about this is that mild traumatic brain injury and concussion, sometimes the terms have been used interchangeably, but the real, meat of this topic is in your post-concussion signs and symptoms, or symptoms of traumatic brain injury after the original incident has occurred. So I hope, that clarifies things. We'll keep going down the list here if there's no opposition. Elon Wurtzel has asked, how is cognitive loss measured, especially in previously high-functioning patients where loss is subtle but high based on prior ability, but less than prior trauma? Excellent question. My go-to answer for this is neuropsychological testing, because it's so comprehensive that high function, this is a very common scenario. Recently, I helped a FBI agent. I helped a CEO who was in an IT firm. These are high functional individuals. They are relying on their cognitive and executive function to be functional and productive in their life, in their families' lives, and so on. So I think a neuropsychological testing is very important to establish that drop off in functioning. John, do you have any comments on these two questions? There were such good questions there.
No. I mean, they're in line with what I was saying previously. I just think it's so important that we go to a medical doctor or healthcare provider who really focuses, like you do, on TBI, on other aspects of brain injury, because sometimes a lawyer will go to someone who, shall I say, might delve in TBI once in a while, but it's not that person's focus.
Yeah.
When you're handling a TBI case, a post-concussive syndrome case, you need somebody, a doctor, a physician, healthcare provider who focuses on brain injury for a living, not as a hobby. Very important.
All right. So we'll keep going down the questions here. Joseph Blasco, I love these questions. They're great. Asks, would love to hear Dr. Shams's comment on TBI with a patient who has pre-existing autism, both in terms of whether autism can confound the diagnosis of TBI, but also whether the autistic issues can be exacerbated TBI. Yeah, I think in the very final slide of our talk, I was talking about this. If a patient has, this is the hardest thing as a clinician for us to keep straight what happened before a TBI and what's happened after a TBI. But nonetheless, I can say without any hesitation that a patient with some pre-existing issue, way more commonly than not, their signs and symptoms of a pre-existing condition like depression, anxiety, ADHD, PTSD can be worsened after traumatic brain injury. Okay, so I hope that answers the question in a resounding manner. The next question is from Jennifer Wickering. It says, how fast should imaging be done in a toddler who has hit their head? So I have dual training in pediatric neurology and adult neurology, and this is a hot button issue in any sort of pediatric emergency room. So if a toddler in neonate, a young adult, right, has had head trauma, if there are any positive neurological signs and symptoms, the ones in the cranial nerve function, if there's any nausea, vomiting, if there's any eye movement problems, if there's heart rate variabilities, imaging should absolutely be done. Often, emergency room providers and clinicians are also trying to balance the exposure of x-rays. Studies have shown that kids who've been exposed to multiple x-rays at a young age have a higher incidence of lymphoma much later in life. So I think it's a little bit of a balancing act, but as long as, there's one of two scenarios. Sometimes a toddler comes in and there's documentation of at least two exams separated in time, by two different providers, maybe a nurse and a doctor says, 30 minutes apart, 60 minutes apart, this toddler is doing fine. They're walking around. In that situation, a clinician gets a little bit of a leeway in the judgment. Like, should I expose this person to an x-ray? The kid is playing with their toy. There's no distress. On the other hand, if there's any positive signs, heart rate, nausea, vomiting, eye movement problems, confusion, we definitely go for imaging, because we know that the blood vessels in a younger brain are more fragile. We know they're susceptible to more injuries. So doing imaging early is very important. It is a case-by-case question. So we'll keep moving. David Foster asks, if all diagnostic imaging is negative, does that rule out TBI and or long-term post-concussive syndrome? Yeah, this is one where I think the only thing to think about is that you can have a negative CT scan, a negative MRI, negative EEG, but your neuropsychological testing can still be a supportive piece of evidence. But I think on balance, this makes your case a little bit harder. But nonetheless, John, what's your experience with this? Why don't I have you weigh in? I'm sure you've seen a case like this where everything is coming back normal, but the person says, hey, I have headaches, I have terrible migraines. What do you say to this question?
John, sorry, you're muted at the moment.
Oops, sorry. As a lawyer, if someone were to bring a case to me and it's true, every mode of testing is negative, including CAT scan, MRI. Let's say they've done DTI. Let's say they've done all of the tests imaginable, plus neuropsych testing, and it's all negative. I would say no. That would not be a TBI case that I would want to move forward with. That would not rule out, though, something like headache. You can have a migraine headache going on, and there's no test that shows the migraine headache, and that becomes something subjective, whether or not a judge and jury are going to believe it. So to me, the key is I want to have a doctor in whom I have faith and confidence to give me the opinion. And if I have a doctor who I really trust, who is going to look at it and say, look, I'm going to give you a forthright opinion here on whether or not there really is a TBI. I want to hear it from that doctor. And if, for example, he or she were to say there's no TBI, I'm going to go with that if it's the doctor that I trust. But I want to make sure that I've done everything as a lawyer to rule out, to do every test. Remember this, you've got probably, I'm going to say 25 or 30 tests to either diagnose, confirm, or verify TBI. I want to go through the run of those tests. I think that's very important. We owe it to the patient, and it's up to us as a lawyer to see to it that they're done. But if the question is, if, quote, every, end quote, test, every tool comes back negative, no, I would not take that case, at least insofar as taking it as a TBI case.
Great. We'll keep moving forward. Kern Lewis has asked, can heart rate variability lead to syncopal episode? Excellent question. One of the signs and symptoms of traumatic brain injury can be syncopal episodes. And when we talk about confounders, folks with blood pressure issues and or heart rhythm abnormalities, which is quite common above the age of 50, can have syncopal episodes also. So I think, really looking at primary care, internal medicine doctors' notes that these patients were heart healthy, that's a very important thing. We also see that sometimes incidence of syncope is a little bit higher in younger female population. I think this is something very good to look at if there's any pre-existing, we call it orthostatic hypotension, as in like positional changes in blood pressure. That's something good to look at. So I think any sort of symptoms of syncope really needs to be taken in context, but traumatic brain injury can certainly lead to people passing out frequently or having syncopal episode as a result of that heart rate variability. So another excellent question. The next question is from William McMurray. He asks, does a single mild traumatic brain injury put the patient at an increased risk of dementia down the road? So this is a loaded question for sure. I would say that it depends. It's a multifactorial answer. If the person has a family history or a genetic predisposition to early dementia, it certainly makes the situation complicated. But typically, there's not like a singular body or a set of database that have tracked patients long enough that I know of. You'd have to track a group of patients who had traumatic brain injury for almost their entire life to conclusively say that a single mild traumatic brain injury would lead to increased risk of dementia. I think you can find evidence for both, but it's a little bit equivocal, and I want to be balanced in my answer to this question. But certainly, you've seen this play out in a sports concussion setting, especially professional athletes who've had traumatic brain, supposedly, return to play for after concussions, mild concussions, and so on. We've seen this in Junior Seau. Many NHL and NFL players have certainly suffered, even within 5-10 years of retirement, some serious cognitive deficits, early dementia-like symptoms. So that's a whole entity that's been described as chronic traumatic encephalopathy. So we'll keep moving here. There was a question about the term DTI. The T stands for tractography. I think there was a question of if I had said cratography. It's tractography as in interconnection between different brains. Stephen Tenenbaum has asked, will insurance cover a DTI? If not, how expensive is it? To my knowledge, insurance companies do not cover DTI because it's not considered an essential study for day-to-day medical care. The cost can vary up to $2,000 to $2,500. This is my basic understanding of it, but you may have to check your local MRI DTI centers. Scott Carr says, when would you recommend a client with TBI get video nystography performed? That is in response to what type of symptoms and what type of doctor performs this testing? Excellent question, Scott. The answer to this is as long as there's some eye movement problems. Some people will tell you they have blurry vision, and even in a layperson, let's say in your intake room, in a clinician's room, sometimes I find patients who have excessive flickering or tick-like movements of their eyelids that happens after trauma. So those are the patients that are ideal for video nystography. The next person is anonymous attendee. I feel like I'm in one of those like newspaper columns, right? Like they anonymize their name, right? What minor TBI treatment can keep the patient engaged in recovery while they remain fully employed? Okay, let's expand on this question. What minor TBI treatment can keep the patient engaged in recovery while they remain fully employed? Does somebody want to, maybe, Ricky, do you want to chat with this person to see? I'm not maybe following the question. I haven't quite, if anybody wants to give some context for this question.
Doctor, while Ricky is doing that, let me ask you a separate question. Many of our clients with a TBI
Sorry, I think John is frozen at the moment. Oh, there we go. John, can you hear us?
Yes. Yeah.
Sorry, John.
I can hear you fine. Can you hear me?
Yep. There we go.
Okay.
Sorry.
Let me quick question for the doctor. Doctor, many of our clients tell us when we ask about the crash, they'll say, "I have no recollection of the crash at all." How important is a lack of memory of the incident where we say it caused the TBI? How important is that lack of memory to you in diagnosing, confirming, verifying TBI?
John, if you could reiterate the final statement one more time. I was screening the questions.
Yes. When a client says that he or she has no recollection of the crash or the wreck itself, how important is that to you in either diagnosing, confirming, or verifying the existence of a TBI?
Yeah, it's an excellent question. The absence of something doesn't necessarily mean that absence of self-reported event doesn't necessarily mean that there hasn't been objective or quantifiable damages. So in other words, we kind of referred to this at the very beginning of our talk, that the fact that somebody has head trauma, that can lead to temporary, very like small 30-second, 60-second loss of recollection or memory if they had a severe loss of consciousness or not. So by the time EMS team, police officers arrive on site, the patient or the client here may not recall any of this. But the proof is really in the signs and symptoms that may persist much longer beyond that. There are so many TBI cases where a patient has a normal CT scan, there's no fractures, they get sent home. But guess what? 2-3 weeks later, they have started to have kind of this onset of symptoms. And once again, I think this is where your specialists come in. This is where these tests come in, and you really have to take a good inventory and kind of work through these cases. I don't think there's a simple answer, but John, I think that the proof is always in the details, kind of tabulation and analysis of like, all right, let's get down to the nitty gritty and look at the symptoms that your client has, right?
Wow.
Yeah.
Great. No, thank
Good.
you.
Okay,
Ricky,
so we'll keep
we have
moving.
the other questions?
Oh, there's still more. How are we doing? We're at 11:23. We'll go 5 more minutes. How's that? And there have been some prolific questioners, so I think I might pick folks who haven't answered questions. Rhonda Kelso has asked, do the colors translate to anything on the DTI? And the answer is yes. A neuroradiologist who specialized in interpretation of DTI will give an input into the color coding. The color coding is based on like short track, long track, and different functionalities. And the color coding really shows you which part of the brain is connected to the other. So there's an entire field of mapping the brain and their functionalities. So a neuroradiologist specialized in DTI interpretation is the person who would offer that expertise. Okay, that's the color coding part. Let's see. We'll keep moving. Kern Lewis has asked, can TBI-induced heart rate variability lead to syncopal episode for years after the injury? Kern, I'll say briefly, I think we talked about the heart rate variability question. Syncope can definitely persist for years beyond traumatic brain injury. You just want to make sure that the person doesn't also have another heart rhythm or blood pressure issue that is so common in the general population above the age of 50. That was a nuance. James Verastro has asked, real question, can you have TBI injury without a diagnosis of concussion and with a normal CT MRI? Once again, resoundingly yes. If you've joined this webinar, I think the one take-home point is that you can have a normal CT scan, a normal MRI, and certainly have traumatic brain injury signs and symptoms for weeks and months beyond for all of the impact forces we talked about. Let's see. And John, I might involve you in this question. It says, how can attorneys explain if a patient does not express symptoms of a possible TBI until months after an accident and after a DTI is done when we can show there is a TBI? So I think this is a question about late onset. You have more courtroom experience. Maybe you can take this one. Like, what if a patient comes in months and months later, time has passed? What do you do in those situations?
Yeah, I mean, I had this happen recently in one case where there was a collapse of a building. A man went down 3 floors, among other things, sustained a head injury, and it was categorized as a mild TBI. He was seen in the emergency room, and there's nothing in the emergency room records about a head injury as to complaints from him, although it does show markings where there was a blow to the head. He does not see any doctor after he leaves the emergency room for approximately 1 year. He then is experienced headaches and some memory problems, and his wife says he's been behaving differently, and she insists that he see a doctor. So he goes to see a doctor, and the doctor says that he has post-concussive syndrome and a brain injury. Then he comes to us. Well, I know what we're going to get from the defense. We're going to get, if he had a real brain injury, he would have gone right to a doctor. He would have seen other doctors. There wouldn't be a year gap in the treatment. I would simply have a physician like you be ready to explain that is a valid TBI case. The man went to the emergency room. There was a blow to the head, but he didn't go running to see doctors because we're all different. Some people go right to see doctors for problems. Others want it to just go away and they try to work through it. And I have found that if jurors see that a plaintiff is credible in most aspects of his or her life, then they will believe that person when on the witness stand. Just one example, jurors love workers. They love people who are employed or who are trying their best to get employed or stay employed. If you have someone with a more minimal injury and all of a sudden they're not working, jurors don't understand that because they know that people who are paralyzed are working. So those are some of the ways that I would try to explain that. But we have a lot of the mild TBI cases where that's exactly what happens. There is a considerable gap in treatment.
Yeah, that's great. So we'll keep moving forward. I was screening through the questions. I want to acknowledge Megan Preacher, Lisa Fuentes, Sylvia Jared, Rihanna Gertz. You guys have asked excellent questions. Let me summarize some of the themes. There's a lot of detailed questions on DTI. What do these tracts mean? And I think, Ricky, Michael, one of the things we may consider doing, I think you guys will have to tune in for part 2, where we will, I think it would be high yield if, as a group expert institute, we brought in a diffusion tensor imaging expert who can really talk about a neuroradiologist who interprets these studies, because the color coding are based on molecular abnormalities, and then MRI and CT scan are more structural abnormalities. Now, sometimes everything lines up perfectly, but sometimes you get incongruencies in these studies where MRI is normal, but the DTI is abnormal. And what does this mean? How do you present this? So I think there's a lot of really, really good questions here. Ricky, I don't know if you can see the Q&A, but certainly it'd be great to copy paste these. And let's bring on a neuroradiologist who can do this, right?
Yeah, folks.
Thank you,
Absolutely.
everyone,
I think
for asking wonderful questions. I'll turn the table over to our moderators here.
Yeah, these are excellent questions. These are ones that we're going to save, we're going to keep around and try to either get back to you individually or incorporate them into the future discussion that we have or plan on having. I think it's perfectly logical to dive even deeper into this topic, given that there's so much interest in it. Having somebody like a neuroradiologist, a DTI specialist, speak to even more of the nuances within this imaging modality, I think is the perfectly next logical presentation to have. But I think that is just about time for us today. Folks, everybody who is on this presentation, you're going to receive the actual recording and the slides themselves. I just want to remind everybody again that in addition to those two things, you will receive the option for a discount code across our services at Expert Institute. But as we wrap up, I really want to thank John Romano and Dr. Tenzi Shams for taking their time to go through this incredibly important topic and doing such a fantastic job minding these great questions we've received in the Q&A. So with that, I say thank you to everyone who has joined, and thank you to the speakers. And hopefully we will see you next time. But after this, we shall be in touch via email. Thank you, everybody.